A very good afternoon to all our SARS members. I welcome everyone for the fifth clinical meet for this year. Today we have got 4 oral presentations and 2 poster presentations from the departments of microbiology, urology, ophthalmology, and emergency medicine. And I take this opportunity to welcome our chairperson for today, Dr. Vallabha, Professor of Ophthalmology. Welcome to you, sir. Please occupy the chair and take over the proceedings.
Thank you, Dr. Krishnamurthy. I would like to thank SARS chairperson, Kotanama, secretaries Krishnamurthy and Sandhya Category for inviting me to become chairperson of this session. That is our channel with the clinical meeting, SARS. So, as Dr. Krishnamurthy said, there are 4 cases of oral presentation, 2 posters. And I request all speakers to restrict the time of 5 minutes for oral presentation and for 3 minutes. So first of all, I will call Dr. Rashmi Karigoda presentation, that is the comparison of active and passive methods of air sampling to evaluate microbial contamination of air in operation test.
So, good afternoon, everyone. Myself, Dr. Rashmi from Department of Microbiology. So, I am presenting my study on comparison of active and passive method for air sampling to evaluate the microbial contamination of air in operation theaters and intensive care unit. So, coming to the introduction, so microbial contamination of operation theaters and intensive care units in hospitals are becoming major problem leading to nosocomial infections. Approximately 10% of these nosocomial infections leads to serious complications like or consequence like increased duration of hospital stay, cost, mortality, morbidity among the admitted patients, and not only the mortality and morbidity, there will be increase in multi-drug resistant strains of the organism. So it is microorganisms that cause infections in the hospital. They originate from the patient's own endogenous flora, healthcare personnel, and environmental sources. The contamination of the OT have been reported through multiple reservoirs like air, ventilation system, wound drainage, surgical team members, OT traffic, OT dresses like footwears, gowns, gloves, improperly sterilized OT equipments, or it can be a contaminated environmental sources, wall, flooring, everything. So you should be careful and you should take a strict precautions to reduce the nosocomial infections which result from these contaminated sources. So the most important goal of any OT or ICU should be in reduction of microbial contamination of air, surfaces, and equipments. This will ensure better patient outcome and will reduce the cost of antibiotics and also the patient's duration of hospital stay, and in turn the decrease in the number of multi-resistant strains of organism. So hospital environmental control procedures are effective in reducing the nosocomial infections, which can be achieved by strict microbiological control methods. Through air sampling, we have many methods, and one of that is air sampling. Through air sampling, it is possible to assess the high-risk microbial contamination in OTs to prevent nosocomial infection. Thus, there is an importance of microbial surveillance of environmental sources. So in the past couple of decades, there has been increasing evidence concerning environmental contamination to acquisition of nosocomial pathogens leading to healthcare associated infections. For this reason, it is important to have the knowledge of the method used to assess the microbiological quality of air, surfaces, equipments in the hospital environment. So in this context, the present study was undertaken to assess and compare the microbiological contamination level in operation theater by active and passive methods, and also to assess the microbial contamination of surfaces and equipments in OTs and intensive care units. So material method study type, it was an experimental and comparative study for 2 months conducted at BLD study material, we included 15 operation theaters, 10 ICUs, and environmental surfaces like floor and wall from all 10 OTs and 10 ICUs, and equipments like OT tables, anesthesia machines, cots, ventilators, and all the instruments which are there in the OT and the ICUs were also taken. And samples from air, surfaces, and equipments from OTs and surfaces, equipments from ICU or OTs, they were included after fumigation at rest. This was the inclusion criteria. After fumigation at rest were included, and before fumigation were excluded from our study. So sample collections, we mainly dealt with 3 sampling procedures. For air sampling, we have done active and passive method, 2 methods, and for surfaces and equipments, we have gone for the swabbing method technique. So all the swabbing procedures, all sampling, all the 3 active, passive for air sampling and swab technique for the surfaces, we have done for all the 3 samples per each OT and ICUs in duplicate, and per day per each OT and ICU was selected. Each day only 1 OT or ICU was sampled. In all the methods, we use nutrient agar, blood agar, separose dextrose agar, labeled with sample number, time, date, and collections of the use. They were all taken in a sealed plastic container, and air samples were taken from all OTs by active and passive methods simultaneously, each OT by 2 methods. Swabs from surfaces and equipments were taken from all the OTs and the ICs. So coming to the method, as I told you, there are mainly 2 methods for air sampling, active method and passive method. Coming to the active method, so we need a system. That system is called as air petri dish sampling system. This we have got it from iMedia. Was used for air sampling. There are many other manufacturers who will give different types of systems. This is from iMedia, which is accurate, and was used for air sampling with medias like nutrient agar, blood agar, severus dextrose agar. Mainly we use blood agar for fastidious organisms, nutrient agar, all the basic, which with basic nutrients they will be grown, and STA we use mainly for to see the growth of fungal organisms. This system, air sampling system, sucks air through the perforated plate. The air containing particles were impacted onto the culture media surface in a standard petri dish plate. After collection of air samples, the plates were removed from that instrument and incubated at 37 degrees centigrade for 48 hours to see the growth of bacterial, and for 7 days for the fungal growth. And then the colonies were counted and expressed as colony forming units. So this is a air sampling system, active air sampling system. Here there will be a opening. We should open this and we should keep the plate. Passive method, passive air sampling, we are done by 111 scheme. In this, the petri dish plates of the diameter 9 cm containing culture media were placed on 1 hour, 1 meter above the floor, about 1 meter away from the wall in OTs and ICUs. These exposed plates were incubated at 37 degrees centigrade for 48 hours for bacterial growth and 7 days for fungal growth. Results were again expressed as colony forming units. This is the table for collecting the samples by settle plate method. Samples from the surfaces and equipments were taken with the swab, moistened with normal saline, and then they were put in the glucose broth, and they were again inoculated onto meconic agar and blood agar, and we have to see for the colony growth. And statistical analysis was done by using mean and standard deviation. Coming to the results, out of 15 OTs, operation theaters air sampling conducted by active and passive method after fumigation at rest, passive method showed more bacterial contamination compared to the active method, and there was a Gauss difference in the colony forming unit of area between active and passive air sampling methods among operation theaters 1, 6, 10, 14, in which passive method showed nearly twice the colony forming units compared to active method. So you can see here OT number 1, 6, 10, 14. By active method, it was only 10, 6, and 3, but in passive method, we could almost detect double the colony forming units compared to the active method. Same thing, we also isolated the fungus. By active method, we could isolate only the pure growth, but by passive method, we could not only isolate the pure growth, in which the growth was not obtained in the active method, but we could also isolate mixed growth by passive method. So comparison of fungus species by active method, only 4% of these microspecies were isolated compared to passive method 9%, aspergillus 6%, but this active method 1%, and candida 1%, passive method 5%. So overall there is increased sensitivity and increased detection rate of this fungus by the passive method compared to the active method. So out of 140 swabs collected for surfaces and equipments, 90 were from OTs and 50 were from ICUs. Among the 90, 10 swabs showed culture positivity. The organisms were Pseudomonas species, Bacillus species, Klebsiella species. Among the ICUs, the most common organism isolated were Pseudomonas, followed by Klebsiella pneumoniae and the Escherichia coli. These are the organisms which were isolated from the surfaces and the equipments of OTs and the ICUs. So, discussion, the most important goal for any OTs and ICUs should be in reducing microbial contamination air, surfaces and equipments. This can be monitored by environmental samplings like air and surface samplings. The active air sampling procedure method is applicable when the microbial load is less, like in an operation theater. We can go for active method. The passive air sampling method provides a valid risk in assessing the microorganisms as it analyzes the harmful airborne organisms falling onto the surgical site onto the instruments. For this reason, it is important to know which method can be used to assess the microbiological quality of air, surfaces and the equipments. So in the present study, out of 15 operation theaters, by the passive method showed nearly twice the colony forming units. In active method of assessing bacterial contamination of air, the maximum detection was 10 compared to the passive method, 25 colonies forming unit. And statistically, there was a significant finding with the passive method, that is 0.0014% compared to the active method. So same thing, Kaur et al, Napoli et al also, they also documented active method was better, Napoli, but Kaur et al told subtle plate is good, it's a crude method. And in a study conducted by Kashmir also, they have told we can go for passive method. So same thing, passive method was also successful for detecting the fungal growth also. Active method has advantages like we need one air sampling machine and it is costly than the passive method, and it produces noise, that is the main disadvantages. Passive method is most commonly used microbiological air sampling technique in the hospital. The advantages are it is simple and cheap, we can go for this passive method. Disadvantages, particles that are large enough to be pulled by gravity are only collected by the collecting surfaces media. So, in conclusion, regular microbial monitoring tools to evaluate the environmental air, surfaces and equipments are useful for identifying situations that need interventions. However, there are no specific indications and guidelines to be used in air sampling methods. We recommend using the passive air sampling method compared to the active method, which is easy, cheap and no instrument is needed. If the infrastructure and facilities are good enough, we can use both methods hand in hand. Swapping techniques for surfaces are useful, easy and cost-effective methods in resource-limited settings for surveillance of OT surfaces and equipments to monitor the nosocomial infection. So we conclude that passive method is a better way of air sampling and to monitor the hospital-acquired infection compared to the active method. So these are my references. Thank you.
Thank you, Dr. Rashmi, for a good presentation, long presentation.
Yes, thanks.
Double the time.
Yes.
So still it is a work. Any questions from the audience or participating online?
What's
Any questions from the audience?
Yes, sir, we are routinely doing every month, first week of the month. They are doing only by active method, not by passive method. They will do by active methods. So I
have only one question.
Yes, sir.
You can 15 operation theaters.
Yes, sir.
Most of us do not know what is one, what is two, one, two like that.
Yes, sir. Okay, okay, sir. Okay, sir. I should have mentioned. Okay, sir.
Please tell me, which theater has got more infection?
In general, that labor unit was more labor rooms. Number 25 colonies bypassing. OT number 6.
Okay, so
I've not. Yes.
Generally, what tell me that
Yes, sir.
OBGOT
Yes.
has got more chance of contamination.
Contamination.
What about ophthalmology being ophthalmology?
Ophthalmology is not that first. No.
It is least or what?
It is the least. Not least, like we didn't detect any. It was within the permissible limit of 10 coliforming units per distance.
Thank you. So we'll move on to the next presentation. We'll move on to the next presentation by Dr. Abhijit Samal, PG in PG in neurology. Study of preventable diagnosis in Indian population and its clinical implications. Speak to Can
Yes, sir. Good afternoon, everyone. Reverend Judge, I'm Dr. Abhijit from Department of Urology, second year resident. Today, I'll be talking on my original research, that is the study of ureteric diameter in Indian population and its clinical implications. It's basically a prospective observational ongoing study, which is not yet concluded. The data that I have projected here and the statistical analysis is just a part of the total sample size. Introduction. Till date, most of the literature that is available regarding the ureteric morphometry is based on Western population and books that are written by Western authors. While making decisions regarding ureter in situations like ureteric calculus, the clinician must be aware of the dependence of the ureteric dimensions on the ethnicity of the individual, independent of the various anthropometric indexes. Assessment of the ureteric diameter is essential for the management of small ureteric calculi and to predict the passage of such small calculi with or without the use of medical expulsive therapy. The medical expulsive therapy is basically alpha blockers like tamsulosin, silodosin, and alphazosin. CT urography, that is the contrast enhanced CT scan involving of the kidney, ureter, and bladder, is the primary imaging modality for evaluating the urinary tract in various clinical settings due to its availability to show the urinary tract anatomy with precision and associated pathologies due to its high sensitivity and specificity, that is both more than around 95% to detect ureteral stones and various other pathologies. The aims and objectives of my study were to measure the dimensions of the ureter at the three known constriction points, that is the pelviureteric junction, the iliac vessel crossing, and the vesicureteric junction, to find out the variation of ureteric diameters across gender and age, and to predict the size of calculus that can easily pass through the ureters in the Indian subpopulation. The type of study is basically, as I mentioned, prospective ongoing observational study. Duration of study is 1 year, and all patients were more than 18 years who were included in the study after fulfilling the inclusion and exclusion criteria. Delayed contrast enhanced CT images of the patients were studied. The machine that we used is the one installed at our BLD hospital campus, that is the Siemens Somatome Scope 32 slice machine. The image studied in soft tissue window in the setting of the CT console software. As I mentioned, the ureteric diameters were documented at three levels, that is the pelviureteric junction, iliac vessel crossing, and vesicureteric junction. One might ask why I chose these 3 points, because these are the 3 anatomical narrowings that are normally present in a human being, and the possibility of a stone, apart from those who have a pathological ureter, will be highest in such scenario. So for that reason, in a normal human being, I have chosen these 3 points. And the ureteric diameter was measured as the largest transverse dimension along the ureter at fixed points, measured using console software-based electronic calipers. This is the image of a normal CT urogram taken in the coronal section. And this is the axial section image of the CT, showing the ureteric diameter to be around 6.1 mm with the white thing, that is the contrast that has distended the ureter. The arrow has been marked to show that. This is basically at the level of L3 level. The inclusion criteria was age should be more than 18 years. The person should have normal serum creatinine value as per hospital laboratory standards, and the urine analysis should also be normal as per hospital laboratory standards. The exclusion criteria, however, were many. We wanted to exclude any kidney or urinary pathology amongst our study population. We also wanted to exclude cases, those who were diagnosed with bilateral ureteric calculus. Any case of the gravid uterus also imposes its weight on the ureter, thereby causing dilatation of ureter, which is physiological, and any diagnosed case or known case of pelvic or colonic malignancy. Apart from that, pelvic endometriosis, history of any pelvic surgery predisposing to fibrotic healing, or history of any retroperitoneal surgery, retroperitoneal fibrosis, or patient who has received pelvic irradiation were also excluded from our study. The statistical analysis, it was done after, it was done in consultation with the statistician. The sample size was calculated based on the ureteric diameter variations that was mentioned in Itani et al. Study, and considering the standard deviation of the ureteric diameter as 1.5 with the precision of around 0.22 and 95% confidence interval. The sample size was calculated using the formula, and it was found out to be around 195. The data was collected, and the participants from the participants, and they were entered into Microsoft Excel, and they were analyzed using the SPSS software. The age and sex were represented using frequencies and percentages. The ureteric diameter, however, was represented using mean and standard deviation. The difference between mean were tested for statistical significance by the student t-test, and the Pearson correlation was used to determine the correlation between age and ureteric diameter. Now coming to the results, this is the distribution. This is the distribution of ureteric diameter across various age groups. The study population had a mean age of around 39.5 years with a plus minus deviation of 13.8 years, and it ranged from 18 to 70 years. Gender distribution around 70.7% were males and 29.2% were females. Here I would like to highlight that these three colors that I have used, the red color is the one showing the maximum and minimum observed ureteric diameter across the pelviureteric junction, ranging from 4.5 mm to 6.8 mm. The yellow line shows the variation of ureter at the iliac vessel crossing, ranging from 1.4 mm to 4.9 mm. And similarly, the blue one shows at the vesicureteric junction, ranging from 1.5 to 4.05 mm. This is the ureteric diameter comparison for the left versus the right ureter with respectively. And this table here shows the ureteric diameter with gender comparison. Here I would like to highlight that at the iliac vessel crossing, and the males had a ureteric diameter of around 3.3 mm with a deviation of around 0.8 mm. However, the females had significantly higher diameter, that is 3.63 with deviation of 0.65 mm, which was statistically significant. There was no significant difference in the mean ureteric diameter between males and females observed on the left side. However, on right side, the mean ureteric diameter was significantly higher in males at the level of pelviureteric junction. When females were considered, the ureteric diameter, as I mentioned, was higher at the iliac vessel crossing on right side, and it was statistically significant. And here this shows the ureteric diameter correlation with respect to age, and we found that it was the p-value was less than 0.05, and at the vesicureteric junction we observed that no age-related ureteric diameter correlation with respect to age on the left side was observed. However, a weak positive correlation with age was noted at the level of uj on right side, which was statistically significant. Now coming to discussion, the present study population has subjects ranging from 18 to 70 years with a mean of around 40 years, mean age of around 40 years. The ureteric diameter on both sides was around 4 mm, that is the mean value, ranging from 2 to 8 mm. And the left ureter diameter had no correlation with age, while right ureter diameter had weak positive correlation at the level of vesicureteric junction. This is a comparison of our study with the 3 other studies that are present in literature. Our study, I would suggest, is superior to the remaining 3 studies because none of the studies have measured ureteric diameter at all the 3 known constriction points, which we have done. We have a substantial sample size, and our study is CT urogram based. However, when seen at for Zelenko et al. And Potenta et al., they had conducted the study after data they obtained from intravenous urogram and non-contrast CT, both of which are inferior to CT urogram. And we have also gone forward with the gender and age variation comparison for the Indian subpopulation. The limitations, however, were the use of visual inspection and direct measurement with electronic calipers, which may give room for individual interpreter variation. That is the subject-based variation will be there. And the sample size is less. Since it is an ongoing study, the sample size will definitely increase. To my conclusion, I would like to say the ureteric calculus of size less than 5.39 mm and 3.46 mm and 2.7 mm at pelviureteric junction, iliac vessel crossing, and vesicuureteric junction can easily pass through without the use of any medical expulsive therapy, thereby saving medical expenditure. However, patient may be symptomatic with pain, lower urinary tract symptoms, hematuria due to the passage of stone when it travels down the ureter, which can be managed successfully by the use of analgesics and hydration. As suggested by the mean ureter diameter in our study, the ureteric calculus less than 4 mm size has the highest probability of passing down. However, this finding can be jeopardized in the setting of any ureteric stricture, external compression over the ureter, or tumor infiltration, or growth compressing over the ureter. Unlike the biliary tree, which dilates with age, a normal ureter is expected to remain basically of same diameter throughout the life. The significance of our study is that we were able to assess the ureteric diameter without incorporation of adjacent soft tissue structures. This has facilitated with the use of enhanced CT, enabling us to establish our local normogram regarding ureteric diameter and contribute significantly to the existing literature regarding the Indian subpopulation. These are my references. Thank you.
So thanks. Any questions from the participants, online participants?
Why sir, we excluded them because if stone is there, then dilatation of ureter proximal to the stone will be there. And for that reason, any ureteric or renal pathology was there, we have excluded, sir. Yes, sir. Yes, sir. Sir, that time, while formulating the various inclusion and exclusion criteria, that time we were unaware regarding the size, what size would be occluding, what size will not be occluding. So to prevent any bias, we excluded, we just incorporated normal ureters into our study.
This is your dissertation?
Yes, sir. No, sir, still ongoing. I'm collecting data still, sir.
How many more cases?
Sir, was this thing sample size is 195. Sir, I'll further. I have reached already 200, and I am still collecting. Since 1 year is still not over because I had started it in December 20th, almost about to be over. So, yes, sir. Yes, sir. Yes, sir. Project, sir. Project that was given to us. Yes, sir.
Thank you.
Yes, sir.
Our next speaker. Is in ophthalmology. Orbital core reconstruction, management of committed orbital wall fractures, following trauma.
Yes, sir. Here is a case of orbital floor reconstruction in management of comminuted orbital fracture following trauma. The surgery was done by Dr. Sunil Biradar sir, Dr. Anand Sajjan sir, Department of Ophthalmology and Department of Dentistry. It was a case of alleged history of road traffic accident following causing collision between two bikes on 19th of November 2020 at 6:30 p.m. near Station Road, India. The patient was brought to casualty immediately. On examination, the BP was 136 by 80 mmHg, pulse rate 95, SpO2 99%, and loss of consciousness was there for 10 minutes. Local examination of the patient showed a cut lacerated wound over right eye, upper eyelid of 4 by 2 centimeter, cut lacerated wound lateral to ala of right side of nose 2 by 2 centimeter with mild nose bleed, and there was tenderness over right wrist. This was the patient. On ophthalmic examination, there was periorbital edema, there was ecchymosis, conjunctiva showed subconjunctival hemorrhage, there was chymosis, cornea was clear, anterior chamber appeared normal, pupil was 4 mm dilated and non-reactive. Lens appeared transparent. Vision was perception of light positive. Patient was not cooperative. Ocular motility could not be assessed due to heavy periorbital edema. On next day, fundus was visualized. Disc appeared normal. The pupils were mid-dilated after adding tropicamide eye drops, though periphery of the fundus couldn't be seen. CT scan report of the face showed epidural hemorrhage seen along right temporal convexity, subdural hemorrhage seen along right frontal convexity of width 7 mm, comminuted fracture of right frontal sinus, lamina papiacea, ethmoidal complex, and all walls of maxillary sinus with hemosinus within. Comminuted fracture of roof and lateral wall floor with inferior rectus entrapment and medial wall with preseptal edema. There was also comminuted fracture of right zygomatic arch, temporal bone, and pterygoid plate. This was the CT scan showing medial wall fracture and lower floor of the orbit fracture, also showing muscle entrapment. Also, there was lateral wall fracture, which had also caused the disfigurement of the face. Conservative management was advised by ENT and neurosurgery, including injection Cefera, injection amikacin, injection ornidazole, injection pan, injection dinapar, injection thymine, injection pause, injection mannitol, tablet amoxiclav, zerodol, and tablet chimeral fort. ENT gave nasoclear nasal drops, Bortoclot nasal drops, and T-back ointment local application. The following that the procedure was following procedure was done for orbital floor reconstruction with titanium mesh. The procedure was as follows: under general anesthesia, painting incision was made 1 centimeter below lower eyelid and through infraorbital approach, orbicularis oculi muscle and periosteum were separated from the bone, and after that inferior orbital rim and maxillary bone fracture was noted and exposed. The 3 bony fragments, comminuted fractures noted, and the prolapse of fat into anterior into sinus atrium was noted. Posterior extent of fracture could not be made out, and the release of orbital fat from the fracture site was done. Titanium mesh was used to support the herniated orbital fat, and the orbital rim fracture was managed by 4-hole with gapped titanium orbital plate. Following it, the orbicularis oculi muscle was sutured, and then the skin was sutured and pad was applied. This is the video. Following incision, there was orbicularis oculi muscle was given an incision, and then there was inferior orbital fracture, rim comminuted fracture was noted. The inferior rectus muscle entrapment was released, and following which titanium mesh was applied, put for the support, and the 4-hole plate was applied to reduce the inferior wall after the reducing the inferior rim fracture, and following that the incision was sutured. Post-operatively, patient had enophthalmos. Ocular motility was improved though. Visual acuity, which was perception of light before, had improved to 2 meter. Fundus following 1 week after the surgery showed traumatic optic neuropathy, for which he was given oral steroid dose in tapering dose. This was the patient post-operatively day 1, and the other picture is post-operatively day 7, which shows enophthalmos. The patient also shows better ocular motility in all directions. Pre-operatively, we couldn't do the ocular motility test though, and this showed restriction. There was no restriction in any side, laterally or inferiorly. The orbital floor reconstruction that with titanium mesh improved the enophthalmos, ocular motility, and disfigurement. Thank you.
This presentation. Patient had diplopia before surgery.
No, sir. No, sir. Before and after both, he didn't have diplopia. Yes, sir. Actually, the vision was only perception of light pre-op and after, post.
So much loss.
The traumatic optic neuropathy was found.
What was the vision after surgery?
Counting finger 1 meter, sir. No much improvement even after 15 days, sir. Steroids are given for the same, and though the patient was happy for better the disfigurement was improved and ocular motility was improved. Yes, sir. Regularly is latest. Still, the inophthalmos is not is there. Sir, Tuesday, 2 days back. Counting finger 1.5 meter. There is improvement, sir. Sir, methylprednisolone tapering dose, it will finish in this week, sir. No, sir, because oral traumatic optic neuropathy has to be managed regressive faster at a faster rate post trauma. As the days of it is more than 15 days, the prognosis is not so good, sir. Sir, we have not done this case orbital flow reconstruction before. It was done with the help of orofacial maxillary surgeon and Department of Ophthalmology together. This was yes, sir. Communicated. Sorry, sir. No, sir. Nothing was done for that. Not required. This.
Thank you.
Yes.
Dr. Agna is going to speak on the study on the ocular morbidity. Patients who are attending rural north or northern.
Good afternoon, everyone. The topic for today's presentation is a study of ocular morbidity of the patients attending ICAM services in rural North Karnataka district, Vijayapura. So the aim of the study is to determine the prevalence and the distribution of ocular morbidities and decrease the visual impairment presenting to ICAM services of Vijayapura. So coming to introduction, about 90% of the world's blind people live in the developing countries, and more than 50% of the world's blind is due to the eye diseases which live in India when you compare with Africa and China. Female to male blindness ratio varies from 1.5 is to 1 to 2.2 is to 1, and about 85% of all the visual impairment is avoidable. Blindness and visual impairment is not only a human suffering, but due to its increasing magnitude, it forms a serious problem in terms of social burden and economical loss. Social and physical function is best explained by day-to-day vision of an individual and is best assessed by one's present vision. The proper understanding of the magnitude of ocular diseases and the factors associated with their occurrence in the community would help us in planning the eye care services according to the various age groups. The study was therefore designed to supply the information about the pattern of ocular diseases in the rural community of Vijayapura. A study depending upon such factors when not being studied in this area, it is considered essential to know the trends of ocular morbidities and finding solutions to solve them. So the source of data is a study conducted by the patients attending the free general eye camps conducted by our college. The study was conducted from Jan 2019 to Jan 2020. It is a prospective cross-section study, and all patients attending eye camp belonging to all age groups were included in the study. Methods. Patient attending free general eye camps was conducted by Sri B.M. Patil Medical College, Vijayapura were examined. Anterior segment were examined using torchlight and magnifying loupe. Best corrected visual acuity was tested, and color vision was also tested with Ishihara's color vision charts. Lacrimal sac disorders were diagnosed based on history, clinical features, regurgitation test, and sac serology. In the case of cataract, it was confirmed by distant direct ophthalmoscopy, and posterior segment was examined by both direct and indirect ophthalmoscopy. Intraocular pressure was examined by digital tonometry and Shear's tonometry. And in case of raised intraocular pressure, were referred to a hospital for final diagnosis. Those requiring cataract surgery were counseled and referred to a hospital where the surgery would be done free of cost for them. The patients requiring further examination were referred and taken to a department for further detailed examination. All the findings were assessed and the final diagnosis were given to every patient. The details of those having corneal opacity were collected and called when suitable donor cornea will be available for keratoplasty procedures. Before screening and examination, the study was explained to detail to all participants of the study, and consent statement was read to them, each of them. As most of the participants were illiterate, informed consent was liberally obtained. So coming to the results, we have found we have got a sample of 877 patients, and among them 686 had ocular diseases. Our study revealed higher proportion of females than males with ocular diseases. Patients examined were from all age groups. In our study, refractive error was a primary ocular morbidity, followed by cataract, dry eye, diabetic retinopathy, glaucoma, and pterygium. Refractive error was found to be more in the age group of 41 to 50, followed by the younger age groups of 11 to 20 years, while cataract was more in the eyes of 61 to 70 years. Glaucoma was screened in 46 cases, of which 15 were male and 31 were females. Investigations such as intraocular pressure, direct ophthalmoscopy, and for visual fields, they were referred to a hospital. And among the 46 cases, 7 had absolute glaucoma with advanced cupping. Diabetic retinopathy was also screened in about 55 patients, and 26 had mild non-proliferative diabetic retinopathy, 19 had moderate, 7 had proliferative diabetic retinopathy, and 3 had vitreous hemorrhage. So this graph shows a comparison between male female. In most of the diseases, female had showed the higher prominence, while in cataract there was a slight increase in the male domination. This again shows the schematic diagram showing the total prevalence of the highest being the refractive error, followed by cataract. This is an age-wise ocular morbidity graph, which shows the highest among the cataract. The highest was among the age group of 61 to 70 years, while refractive errors was highest between 41 to 50 years and 11 to 20 years. Coming to discussion, the study shows highest prevalence of female to male ratio. The females showing higher rate of ocular morbidity as they are the most neglected group in the society, and them approaching the hospital is difficult. Hence, these ICAMs give them an opportunity to get examined and treated at the earliest. In the study, the highest rate of refractive errors were among the 41 to 50, followed by the younger age. Refractive errors were prevalent in the age group because they presented with presbyopic errors, and the younger group were presented with myopic errors. According to the study by Singh M. Mental, the prevalence of blindness was 12.2 and the low vision was 32%. And the main cause of the visual morbidity in that study were also cataract and refractive errors as in ours. Among the cataract patients, majority presented with immature, followed by mature and hypermature. About 5% of the patient presented with phacomorphic glaucoma. ICMR collaborator study showed variation in the prevalence of cataract ranging from 30.1 to 72.2% in different parts of India. The prevalence of visual impairment and blindness varies geographically due to socio-economic factors, availability of health services, and awareness of eye diseases among the population. So in conclusion, the majority of causes of decreased vision among the study group in the survey was avoidable, and which like refractive errors, which is followed by cataract. So stable intervention programs targeting cataract, refractive errors, glaucoma, diabetic retinopathy may significantly decrease the burden of visual impairment in this area. There is a need of new strategies for early detection of ocular diseases and to provide visual rehabilitation to the poor rural people, as majority of causes of ocular diseases are either preventable or treated. Thank you.
Thank you, ma'am, for this presentation. When this article for publication be developed?
I would like to send, sir, before
Send.
yes.
Okay. Because compared to collaboration, yes, no, okay, the first question is not has false and one important thing you want to highlight here is most of the patients we get with the camera is females.
Females, yes.
Most of the patients we get in the hospital is males.
Yes.
It is 70, 30, 37 lakhs. charts are very successful, very useful for the female population. Which are neglected to the general population. Any questions from the audience?
Nutritional efficiency disorder affecting the eye of
Sorry, sir.
nutritional efficiency disorder only the
The children would around 2% of the kids present with vitamin A deficiency, sir. And they present with late complications like conjunctival xerosis and corneal melting.
So the separate study we have taken for ocular morbidity in schools.
In schools, sir.
Study was there. It's a complete complete. And thank you. Now, after our presentations, now we want to posters. Poster presentation. First poster, Vidyajam versus Dinosing as a first line drug. The physician will remain pharmacological termination of stable supraorbicular pigment PD.
Yes. In the emergency department. Zoom. You can't zoom it. Zoom.
Slide down with relay. ಇದನ್ನ ಮೂವ್ಮೆಂಟ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ.
ಹಂಗೆ ಓಪನ್ ಮಾಡಿ ಹಂಗೆ ಹೋಗ್ತೇನೆ. ಕ್ಲೋಸ್ ಹಾಕ್ಬೇಕು. ಓಪನ್ ಝೂಮ್ ಮಾಡಬೇಡ. Good evening, everyone. Today I'm going to present a case where, the topic is diltiazem versus adenosine in reversal of a stable, narrow, complex supraventricular tachycardia in emergency department. Introduction. Supraventricular tachycardia are tachyarrhythmias that originate from or are dependent on conduction through atria or the atrioventricular node to the ventricles. Narrow complex supraventricular tachycardia are common cardiac emergencies that are faced in emergency department. AVNRT being the most common. Vagal maneuvers and adenosine are the first line recommended treatment in terminating a narrow complex stable SVT. However, there are few studies which suggest usage of diltiazem as a first line in conversion of SVT to a normal sinus rhythm could be tried as it has a higher success rate. Here we share a case report where a supraventricular tachycardia was treated with both adenosine and diltiazem in emergency medicine department. Case report. A 28-year-old male presented with complaints of palpitation lasting for 2 hours, which was sudden in onset. He had history of similar complaints on and off in the past 1 month. No history of chest pain, giddiness, or syncopal attacks. No comorbidities. On examination, the patient, he was a young male, moderately built and nourished, well-oriented to time, place, and person. His AB was patent. He was breathing at a rate of 22 cycles per minute, maintaining a saturation of 98% at room air, with normal vesicular blood sounds on either side of his chest. And BP was 110 by 80 mmHg. Pulse rate was 230 beats per minute, a regular good volume pulse. S1, S2 was heard, no murmurs were heard. CNS examination revealed a GCS of 15, moving all 4 limbs. He did not have any pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or edema. Initial ECG was taken. ECG showed tachycardia with narrow complex QRS. P wave were followed after QRS and it was inverted, which made a provisional, we made a provisional diagnosis of supraventricular tachycardia. So, initially, patient was put on continuous cardiac monitoring and vagal maneuvers were tried to terminate the tachycardia. However, when the vagal maneuvers failed, injection adenosine 6 mg IV was given through antecubital vein, the left antecubital vein, followed by a 20 ml NS flush was given. When the rhythm did not revert to normal sinus rhythm, another 12 mg of adenosine was given. Still, the rhythm wasn't corrected, so a repeat adenosine of 12 mg was given. Once, when the SVT was not corrected normal sinus rhythm with adenosine, Patient was then shifted to diltiazem. Injection diltiazem 0.25 mg per kg IV was given over 2 minutes. SVT was corrected to normal sinus rhythm with heart rate of 90 beats per minute. Post diltiazem, patient did not go into hypertension and BP was still maintaining at 110 by 70 mmHg. And during the 2D echo revealed no regional wall motion abnormalities. So during the next 24-hour observation period, patient did not experience any palpitation or did not have any other symptoms, and his ECG showed normal sinus rhythm. Coming to discussion, supraventricular tachycardia is caused by one of the three mechanisms, which is either re-entry, increased automaticity, or triggered activity. SVT can be of brief duration, called as non-sustained, or it can be sustained such that intervention like cardioversion or a drug administration might be required. Episodes that occur with sudden onset and have sudden termination are called as PSVT, that is paroxysmal supraventricular tachycardia. And it refers to a family of arrhythmias, including AV nodal re-entry tachycardia, atrioventricular re-entry tachycardia, wherein a necessary pathway will be present connecting the atria and the ventricle, bypassing the AV node. So, AVNRT is caused by a re-entry circuit involving the posterior and the anterior inputs in the compact AV node. AVRT requires a presence of an accessory pathway, as mentioned earlier. The symptoms usually are palpitation. Sometimes they might have giddiness and even syncopal episodes. ECG will show narrow complex QRS tachycardia, and there will be presence of pseudo R dash pattern in lead V1 and pseudo S dash pattern in the inferior leads like lead 2, which is usually classical in AVNRT. While in case of AVRT, there will be QRS alterance seen. And for initial termination of a stable SVT, especially in the emergency department, what is being told earlier is to try vagal maneuvers and then go for adenosine. But however, in the case that we encountered, the SVT could not be reverted to normal rhythm with adenosine. So diltiazem was successful in reverting it to normal sinus rhythm. Also, the mechanism of action of calcium channel blocking is efficient, as the AV node action potential majorly depends upon calcium activity during its depolarization. So hence these calcium channel blockers are effective in termination of SVT. Diltiazem also has lower incidence of hypertension as compared to verapamil. Conclusion: diltiazem can be preferred as the first line medication instead of adenosine in termination of stable narrow complex tachycardia in emergency medicine department. I'll show a video of the same case wherein so as you can see, the patient is there. As soon as we give diltiazem, immediately the rhythm converted to normal sinus rhythm. And this is not with adenosine, this is diltiazem. And he maintained his heart rate around 90 to 100 during his 24-hour observation period, and BP was also maintained.
Thank you.
Thank you.
Thank you. Any questions from the audience? Next post presentation by Dr. Prosthetic tumor masquerading as GPA.
Good afternoon, respected sir. Myself, Dr. Abhishek from Urology Department, and I would be presenting a poster on a rare prostatic tumor masquerading as clinically as a BPH. So, for introduction, prostatic tumors may be benign or malignant, and adenocarcinoma is the most common malignant tumor in prostate. Benign tumors usually include inflammatory myofibroblastic tumor, which is very rare, and it is usually found in lungs and abdominal cavity, mostly in the peritoneum. And in the urinary tract, kidneys and bladder are the most common sites. However, like very few cases, around 10, are presented or like reported previously in the prostate. So here we present a case of prostatic inflammatory myofibroblastic tumor in a 44-year-old male. So the patient is a 44-year-old gentleman who presented to ER with gross hematuria. Apart from that, he had history of obstructive LUTs, that is lower urinary tract symptoms associated with burning micturition. He also had history of recurrent urinary retention. So when he presented, his bladder was palpable and he had a grade 2 prostate on digital electric examination. On further evaluation, ultrasound showed a 40 cc gland. The kidneys and urinary tract were normal, and along with this, the bladder had few sediments and blood clots. So urine analysis showed 8 to 10 parcels, and PSA was 4.4, which was like grossly normal. And so the patient underwent a TRUS, which showed a irregular heterogeneously echoic mass on the right lobe of prostate protruding into the bladder base with significant vascularity. So the patient was subjected to transurethral resection of the prostate because of recurrent urinary tract retention, and the cystoscopy showed a large pedunculated mass on the right lobe of the prostate. So the TRP chips were sent for histopathology, which showed a proliferation of widely dispersed spindle cells with a myxoid background, with mild nuclear atypia with less than 1 mitotic figures. So this was suggestive of an inflammatory myofibroblastic tumor, and it was confirmed with IHC, which showed spindle cells positive for actin and negative for S100 and desmin. And coming to the discussion, a similar tumor was first reported in 1984 by Rowe et al. And he termed it as pseudosarcomatous fibromyxoid tumor. And the usual age of presentation is around 22 to 80 with a median age group of 50 in the literature. The etiopathogenesis, though unknown, and it's like they have suspected it to be due to smoking, past instrumentation of the urinary tract or surgery. And one other differential diagnosis for this lesion is a post-operative spindle cell nodule, and which has a similar histological appearance. It was first reported by Prop et al. And these tumors usually originates post any invasive trauma to the urinary tract. And to differentiate from this, like our case didn't have any previous past history of trauma or instrumentation of the urinary tract, and it also had low mitotic counts, contradicting to the post-operative spindle cell nodule. So like inflammatory myofibroblastic tumor is considered to be benign tumor with local recurrence potential. They can be locally aggressive involving the bladder, but rarely shows metastasis. So to conclude, despite its rarity, it is important for urologists and pathologists to be aware of such an entity to avoid unnecessary radical procedures of the prostate. And this case is being presented for its rarity. Thank you. Yes, sir. Thank you, sir.
Request all the speakers to collect your certificates. That concludes today's meet. I thank everyone for attending this meet. And I also thank our chairperson, Dr. Vallabh sir, for chairing today's session. Now I request Dr. Vallabh sir to hand over the certificate.